and welcome to the ASCO Guidelines podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Funda Merrick-Bernstam and Dr. Amber Johnson from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Mark Robson and Dr. Debyani Chakravarti from Memorial Sloan Kettering Cancer Center in New York, New York, authors on Somatic Genomic Testing in Patients with Metastatic or Advanced Cancer, ASCO Provisional Clinical Opinion. Thank you for being here, Dr. Merrick-Bernstam, Dr. Johnson, Dr. Robson, and Dr. Chakravarti.
My pleasure.
Great to be here.
Thank you.
Great. I'd like to note that ASCO takes great care in the development of its guideline products and ensuring that the ASCO conflict of interest policy is followed. The full conflict of interest information for this provisional clinical opinion panel is available online with the publication in the Journal of Clinical Oncology. Dr. Merrick-Bernstam, do you have any relevant disclosures that are directly related to this topic?
No.
And Dr. Robson, do you have any relevant disclosures?
Do clinical trials with PARP inhibitors, which are somewhat related to the findings from genomic testing, but no personal compensation.
Thank you. Dr. Johnson, do you have any relevant disclosures?
No, I don't.
And Dr. Chakravarti, do you have any relevant disclosures?
No, I don't.
Great. Then getting into the content of the provisional clinical opinion. First, Dr. Robson, can you give us a general overview of the purpose and the scope of this provisional clinical opinion?
Sure. So I think it's obvious to everyone in oncology that we're in the era of genomics, and that tumor genomic testing is becoming widely available, at least in certain contexts. And there is sometimes a little bit of a lack of clarity regarding when to do it and how to interpret it. So the purpose of this was to gather a group of experts together to share with the membership a framework for considering genomic testing in locally advanced or metastatic solid tumors. So we were specifically not discussing the issue of germline testing in any detail and not reviewing anything regarding genomic testing in hematologic malignancy. But we were addressing a series of questions specifically in the advanced solid tumor space.
Understood. So then this PCO provides key statements across several different sections. I'd like to review those statements for our listeners. So starting with Dr. Chakravarti, what is the expert panel recommended framework for decision-making on multi-gene panel-based genomic sequencing with disease-specific approved markers?
So first, I think it's important to define what we mean in this ASCO PCO by multi-gene panel-based genomic testing. So small gene panel assays have typically been approved in multiple specific cancer types. So, for example, a specific set of genes such as EGFR, ALK-ROS in lung cancer, or BRCA and HRD, homologous recombination deficiency genes in ovarian and breast cancer. These panels typically include a specific set, less than 50 genes in the panel. Multi-gene panel sequencing are panels that are greater than 50, but typically include hundreds of genes. So, for example, the Foundation 1 panel includes 324 genes. MSK Impact that we use includes 505 genes. This is in the context of the whole exome carrying 20 to 25,000 genes, and then the whole exome is 1.5% of the whole genome. And so this becomes important in terms of, which assay to choose for such sequencing. The panels, the multi-gene panel-based sequencing tests, they are able to detect tumor mutational burden and MSI fairly accurately, and Dr. Johnson will go over that in a little bit later. This PCO has been specifically written to address the role of genomic testing in metastatic or advanced, inoperable, locally advanced, or locally recurrent solid tumors. And for the first point, essentially genomic testing should be performed in patients with metastatic or advanced solid tumors if their genomic biomarker-linked therapies are present for that disease as approved by a relevant regulatory agency, such as the FDA here in the US or the EMA in Europe. So we've provided a list of those genomic alterations in the specific indications in Table 2 of the ASCO PCO. This was paused as of June 2021. So there have been additional approvals since then, but we've provided a snapshot in Table 2.
Great. I appreciate you reviewing that statement and providing the definition of what actual testing you're looking at. That's very helpful. So next, Dr. Johnson, what are the key statements for assessment of mismatch repair deficiency and or microsatellite instability high status and tumor mutational burden?
So multiple immunotherapies are now approved for the treatment of any solid tumor that is mismatch repair deficient or has a high tumor mutation burden, or TMB. So if a patient is a candidate for immunotherapy, then assessment of these biomarkers may guide treatment decisions. Importantly, there's multiple tests that can be performed in order to determine if a tumor is mismatch repair deficient. These include immunohistochemistry for mismatch repair proteins, PCR at select microsatellite loci, and multi-gene panel testing to determine if the tumor has high microsatellite instability, which is a consequence of the tumor being mismatch repair deficient. Only large multi-gene panels or whole exome sequencing can determine whether there is high tumor mutation burden, however. The clinician may want to consider the prevalence of dMMR and high TMB within the patient's specific tumor type when deciding whether to test for these biomarkers.
Great, thank you for that overview. So then next, following those statements, Dr. Merrick Bernstam, what did the expert panel recommend regarding testing for gene fusions and exon skipping variants?
Thanks for that question. The area of fusion testing and exon skipping for MET is rapidly evolving, and we wanted to highlight a few different aspects of this. First, in patients with metastatic or advanced solid tumors, fusion tests should be performed if there are fusion-directed targeted therapies with regulatory approvals in a specific disease. Here, we really wanted to highlight that these approvals are happening fairly fast, and treating physicians that are caring for patients that where diseases with fusions have approvals such as ALK, ROS, RET fusions, and FGFR fusions in bladder cancer and cholangio. Oncologists need to be aware of these fusions and should be testing for these fusions. And we'll touch upon this again, but there are next-gen sequencing platforms that sometimes do not incorporate fusions. So it's also important to know whether testing has been ordered and have a planned order in place. Now, in addition to these scenarios where there are disease-specific approvals, there's approval for NTRK fusions in a tumor-agnostic fashion. So this really highlights the importance of considering fusion testing in a tumor-agnostic fashion. So TRK fusions actually are commonly found in some rare tumors like secretory breast cancer or mammary analog of secretory carcinoma of the salivary gland, and is found rarely in some more common diseases like colon cancer, and then maybe a little bit more frequently in other tumor types such as thyroid carcinoma. So it's really important that fusion testing that incorporates TRK regularly get ordered in patients that have diseases where we know fusions may be driving with TRK fusions. On the other hand, if a fusion panel is not incorporated into the next-gen sequencing platform, it should be considered in patients where it's more likely to be found or there isn't the obvious other driver. And TRK fusions are rare, but really TRK inhibitors are very effective when these fusions are found. Also, we're now identifying other fusions that are really compelling, such as NRG fusions. So this highlights that as we do more fusion testing, I think there can be additional therapeutic opportunities for our patients. And then the MET exon skipping is something that's been recognized in lung cancer, and now there's 2 MET inhibitors approved for exon 14 skipping. So again, there's got to be a planned order of MET exon 14 skipping for patients with any kind of histology of non-small cell lung cancer.
Great, thank you for reviewing that information. So then we've talked a bit about disease-specific approvals, but Dr. Robson, what is the suggested framework for decision-making in panel tests with no approved disease-specific markers?
Yeah, I think that this is perhaps one of the most complicated and confusing areas for the practicing clinician. And so we thought about this quite a lot, and you've already heard about 2 situations or 2 classes of agents where there are pan-cancer approvals, in other words, not site-specific approvals, and those are immunotherapies in the setting of high tumor mutational burden or evidence of mismatch repair deficiency, and the situation where there is NTRK fusion being treated with agents that are targeting that. So Dr. Merrick Bernstein laid out pretty clearly, and I think Dr. Johnson did before that if someone is a candidate for immunotherapy, or if there is a possibility that there is an NTRK fusion driving the cancer that hasn't otherwise been evaluated, then consideration should be given to doing multi-gene panel testing with fusion testing to try to identify these patients who may benefit, even if there's no other biomarker approved indication within their disease. The other situation that we run into that's complicated is when someone is undergone genomic testing but has an alteration that doesn't have an approval in their disease, or alternatively has an alteration that doesn't have any approval, but there are drugs in development targeting that particular alteration. And so the encouragement there is to have patients participate in clinical trials, but not necessarily to assume that a genomic alteration targeted therapy is going to be superior to standard therapy. So there has to be consideration given to potential benefits of the clinical trial targeted treatment versus what's available for standard of care. And this then drives into one other circumstance, which is when one has done genomic testing and has identified an alteration for which there is an approval in another disease, perhaps. And in that setting, we would not recommend that the patient undergo off-label and off-study use of such a therapy if a clinical trial is available, or unless there is really compelling clinical evidence that is going to work in their particular disease, because there are certainly context-specific considerations to targeted therapies, and something that works well in one place may not necessarily work as well in another for a variety of reasons.
Absolutely. Thank you for reviewing those considerations. Then we've talked about what types of tests should be ordered, but Dr. Chakravarti, what elements are important to consider while reviewing the genomic testing results?
Yes, there are several elements that you want to take into consideration when reviewing genomic testing results. I think the first would be taking into account whether it's tumor-only testing versus matched tumor-normal testing. So what do I mean by this? Essentially, there are two approaches to determining tumor-specific alterations that arise in a patient's cancer sample. The first is where you take both a blood, buccal, swab, or saliva as a normal sample, and you take the tissue sample of the patient, and you compare the DNAs for both, and you isolate what alterations are there. The second is that there are databases that have compiled the normal or reference genome sequence, and so you compare a patient's tissue sample sequence to the normal sequence that is sort of the reference genome that is available. So tests should clearly state whether only the tumor was sequenced or whether both the tumor and patient-matched normal sample was sequenced. For testing with matched normal samples, the sequencing reports should also specify whether pathogenic or likely pathogenic germline alterations, and by that I mean alterations that are pathogenic and present in the normal sample, are separately reported, or if any and all germline alterations, if detected, are filtered out, irrespective of pathogenicity, and therefore not reported. This latter point is important because, as we know, alterations that are pathogenic can occur and arise in germline, and that requires a whole different series of events, including genetic counseling and so forth. So this needs to be specified in the report. The second element is the targeted sequencing approach. So these sequencing reports should specify which of primarily two targeted NGS capture-based methods are used, either amplicon sequencing, which is faster and requires less DNA, or mutational hotspot regions that are selectively amplified using multiplex PCR. This is with sequence-specific primers. So the actual targeted sequencing approach should also be discussed. The third element is what are the genes that are tested, and those genes should be specified in the sequencing report. Sometimes the test may include introns of certain genes to be able to detect certain fusions. So all of that must be specified in the report so the clinician has an idea of exactly what can be detected in this test. And in line with that, and what Dr. Merrick Bernstrom just discussed, we need to know whether or not fusions, whether they're tested, and if they are tested, what are those fusions that are included in the test report. So that has to be included in the report. And then the two most important elements thereafter are what is the functional annotation of the variants. So we know that patient cancer samples carry several mutations, and depending on different cancer type, the overall mutation burden can be quite high, such as in lung cancer, or low, such as in hematologic cancers. We need to know what are the driver mutations in the overall mutation population in a patient's cancer type. And within the driver mutations, we need to know what are the clinically actionable mutations, i.e. what are those mutations that are linked to a specific therapy. So that functional annotation must be specified in the sequencing report. And then the second part is, and this is, fairly advanced. Many current sequencing reports do not include this information, but it is certainly something that has impact on therapeutic actionability and therapeutic strategies, is mutational clonality. So knowing that mutations arise randomly throughout a patient's disease, those that arise earlier in tumor evolution are clonal and present in virtually all cells. And these, if they are linked to a targeted therapy, if the mutation is clonal, there's a much larger chance of efficacy. Compare that to those mutations that occur late in tumor progression and present only in a proportion of cells, i.e. they are subclonal. So then these may be neutral or contribute to the malignant phenotype in a fraction of tumor cells, and they are often harder to target with a systemic therapy. So this information can have impact on the anticipation of a targeted therapy working. Importantly, subclonal mutations arise sometimes in response to selective pressures imposed through systemic targeted therapies. So that information can certainly be helpful. And you can infer this using variant allele frequency estimates in combination with copy number information. But many genomic platforms and labs do not report copy number or variant allele frequency. And so many of these reports don't include this information, but it's certainly an important element to consider if that information is included.
Absolutely. Thank you so much for reviewing those key elements to help clinicians both interpret and make decisions based off the testing results. So then, Dr. Johnson, what are additional or related topics that clinicians should be aware of as they implement this provisional clinical opinion into practice?
So we believe it's important for clinicians to be aware of the option of sequencing circulating free or cfDNA, particularly when tissue sample is limited or when repeat testing is desired, but new tumor biopsies cannot be obtained. Repeat testing is particularly beneficial when new therapeutic targets are being sought due to acquired resistance to targeted therapy or when initial testing was performed on a limited panel. During interpretation of these results, it's important to remember that a single biopsy may not be representative of all actionable mutations due to heterogeneity within the primary tumor or between the primary tumor and different metastases. Drug efficacy may be limited if the mutation is present in only a small fraction of cells, as was previously described, or if specific co-alterations exist. I believe it's also important for clinicians to be aware of the many other utilities of both somatic and germline testing beyond identifying therapeutic targets. These include identifying biomarkers that are diagnostic or prognostic for a specific disease, And germline sequencing may identify polymorphisms that result in the inability to metabolize certain therapies. Additionally, new biomarkers that are not merely a single mutation, but actually a signature of multiple mutations are becoming more frequently reported within genomic reports. And these can guide clinicians to specific defective processes that can be therapeutically targeted, like homologous recombination deficiency, and they also can help identify a tumor's origin.
Definitely, those are important points to keep in mind. So then finally, Dr. Merrick Bernstam, how will these guideline recommendations affect patients with metastatic or advanced solid tumors?
This is an exciting time where the ability to do comprehensive genomic testing is a lot more available. And I think this provisional clinical opinion will make next-gen sequencing accessible to all advanced metastatic cancer patients that may benefit from the information gained. This will highlight, I think, for patients genomic alterations that already have disease-specific biomarker-linked approvals, but also the opportunities that are tumor-agnostic. And I think it also emphasizes that this additional information may provide research-driven care opportunities.
Absolutely. Well, I want to thank you all for your work to develop this provisional clinical opinion and for taking the time to speak with me today, Dr. Merrick Bernstam, Dr. Johnson, Dr. Robson, and Dr. Chakravartty.
Thank you for inviting us.
Thank you.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full provisional clinical opinion, go to www.asco.org/assays-and-predictive-markers-guidelines. This PCO also has a companion Cancer.net podcast episode. Cancer.net is the patient information website of ASCO, and we encourage you to learn more by tuning into their episode. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.